Last case, I believe, is the most interesting one for me. This is huge cholesteatoma, which nobody might have seen, very few people have seen earlier. See this, why I am saying cholesteatoma. This patient has a dead ear, this patient has a complete palsy, this patient has undergone surgery 5 times in India everywhere, has undergone even cul-de-sac closure, and look at the right temporal bone. Can you see something?
Yes, sir.
Entire temporal bone is full of this enhancing tissue, enhancing activity on T2 weighted MRI. T2 weighted MRI enhancing activity, number one. Look at this is the carotid artery. Look at the situation of the petrous carotid here, and this lesion is completely pushing it.
Yes.
Now, what it could be, the second investigation I will bring together is the contrast. Now see, it is not enhancing with the contrast. Can you see everywhere?
Yes, sir.
This is enhancing on T2, but not enhancing on contrast. That means it's not a tumor.
Yes.
Had this been a tumor, situation would have been exactly opposite, enhancing on contrast and not enhancing on T2.
Yes, sir.
Now, what exactly it could be, to differentiate further, I will bring in another investigation. Now, I will bring the diffusion. See this diffusion. Now, this lesion is showing restriction. Can you see everywhere?
Yes, sir. Yes, sir.
Had this been inflammation, it would have shown diffusion, more and more diffusion. Diffusion characterizes the tissue content. If the tissue has more water content, if the tissue has more cellular, tissue is more cellular, there will be restriction. More water, it would be more and more diffusion. So, for the lesion which is not showing enhancement on the contrast, that rules out the possibility of a tumor. And the lesion which is not a tumor and showing diffusion restriction and hyperintense on T2, it cannot be anything else than cholesteatoma. As simple as that.
Yes, yes.
How to identify the cholesteatoma in MRI? Enhancing on T2, not enhancing on contrast, and showing extreme diffusion restriction. Had this been a malignant tumor, this would have shown contrast. Cholesteatoma would never show contrast. Cholesteatoma doesn't have vascularity. It cannot take up contrast.
Yes.
Had this been a tumor, this would have enhanced on contrast. So, this has ruled out tumor. Now, enhancing on T2, that means could be cholesteatoma, and showing diffusion restriction without a tumor. It cannot be anything else than cholesteatoma. So, these three sequences are required together to label it as a cholesteatoma. Now, as I mentioned, this patient has been operated 5 times.
Operated 5 times, sir.
Yeah, in the various parts of the country. Has already undergone cul-de-sac closure. Was a known case of cholesteatoma. Dead ear, complete facial palsy, and entire facial, the temporal bone is rotten with this kind of a lesion. See this on CT scan. See this, everything destroyed. Can you see on this side?
Yes, sir. Extensive erosions.
Now look at the cochlea on the opposite side. Where is the cochlea? Destroyed.
Yes.
Look at the,
What is age of the patient, sir?
this is around 40, female 40 years. Now look at the carotid artery on this side, normal side.
Yes.
Look at the carotid, all walls destroyed, and it is pushed laterally by a lesion medial to it. There is a huge You can say कि चम्मच भर के निकालना है cholesteatoma, kind of a lesion.
Yes, sir.
See this?
When was the first surgery done, sir? Age
She has been operated for last 6-7 years again and again.
must be around 30, 35.
And during previous surgery had CSF leak as well, history of CSF leak.
Okay.
And the cul-de-sac closure was done. Now, look at the normal anatomy of temporal bone from this side and that side. This, there is no temporal bone existing. Can you see?
Yes.
As compared to this normal temporal bone, here there is no temporal bone existing, and my biggest concern is the carotid artery. Now, if I see the course of the carotid, see the course of the carotid artery on this side, can you see?
Yes, sir.
This is pushed laterally by the cholesteatoma medial to it.
Yes.
Imagine the scenario. We saw the horizontal Petrous carotid artery in the previous two cases. We saw from here the horizontal Petrous carotid artery. In this particular case, the lesion is deep to horizontal Petrous carotid artery, imagine. And gone complete right up to the Petrous apex. This is sphenoid sinus. Can you see? This is sphenoid sinus, and see where the lesion is. Completely destroyed the temporal bone.
Yes.
CSF leak is likely again because we don't have any landmarks. Even the dura and everything is pushed out. History of CSF leak. And as compared to the opposite carotid artery, look at the opposite carotid here. This carotid is so thinned out and looking compressed. Can you see?
Yes, sir.
And this is laterally elevated by this lesion medial to the carotid artery. What a lesion it is.
Sir, now what care to be taken during consent taking of the patient, sir?
Yeah, this is high risk patient. Can have, neurological consequences because they deal with the carotid artery, can invite. Then
Sir,
chances of CSF leak, chances of residual disease also, chances of post-operative infection also, because everything is rotten here.
Yes, sir.
sir, why not some other diagnosis, eosinophilic granuloma or something else?
See, eosinophilic granuloma or what do you call that? Which other granuloma we see in the temporal bone? Cholesterol granuloma.
Yes.
This is T1 weighted sequence. The cholesterol granuloma or any other granuloma enhance on T1 weighted,
Okay.
enhance on T2 weighted, and they enhance on contrast also, which is not happening
Okay.
here.
Okay.
So that rules out. And the kind of diffusion restriction this has given is classically
Of cholesteatoma.
cholesteatoma. So to me it looks like a cholesteatoma, nothing else. Let's see. The surprises are always expected in such extensive cases. It could be cholesterol granuloma. If it is a cholesterol granuloma, then the situation is much easier. The reason being, in cholesteatoma you have to chase out each and every bit of epithelium, not in cholesterol granuloma.
Granulomas.
So that is if this is a cholesterol granuloma, it is a cakewalk.
Okay, sir.
Secondly,
What is your planning now? Planning with
yeah, we'll open and remove whatever, see the limits of the temporal bone all around is visible.
this? Yeah.
We have to remove this entire pathology. We have to drill away whatever remnant of the labyrinth. This is the remnant of the labyrinth.
You'll remove that.
Obviously, this is a dead ear. There is no cochlea, vestibule, nothing.
Okay.
So whatever it
How will
is,
you reconstruct this
and
posterior wall?
after going from here, after drilling this, then only we'll be able to go underneath the carotid artery. We have to go deep to the carotid artery by drilling the remnant of the labyrinth. The biggest concern is the carotid should not lacerate. That I don't know how the wall is thinned out, it is pushed. Thromboembolic consequences after dealing the carotid artery are not uncommon in such situations. So let's see.
Sir,
Hope for the best.
Sir, what will be the causes for such extensive hepar disease, sir?
Left the previous surgeon left the cholesteatoma behind and did a cul-de-sac closure.
Okay, so that will be one of the things. Yes.
And maybe he may not be very sure about it, or maybe sure about it and miss the disease. Number one. Number two, the CSF leak which happened may have forced the surgeon to save the patient by means of closure and preventing infection, imminent infection. So there could be reason, I don't know what it could be.
Any need of addressing that nose also, sir, in this? That nose turbinate is seemingly.
But that is not extensive disease. This is the turbinate, the sinuses are all well aerated.
Yes, yes.
That is not the disease.
But that must be from initial time also, sir. So earlier it could have been taken care, sir.
Yeah, so the most important part of the disease is deep to the horizontal portion of the carotid. We have seen now, until now, this horizontal portion of the carotid. Now we will go right up to the foramen lacerum there, as the disease is right underneath that. So this requires a complete transcochlear approach. Transcochlear approach means destroy the cochlea, remove everything. The anterior limit is the carotid artery, posterior limit is the sigmoid sinus, inferior limit is the jugular bulb, and superior limit is the dura. In between, whatsoever comes, destroy and remove the disease and obliterate.
Yes.
This is the modified transcochlear approach proposed by Mario Sana for such extensive lesion. We use this approach for many of the skull-based tumors, provided the facial nerve is already compromised and the hearing is already compromised. Because in this approach, otherwise you have to transpose the facial nerve, and if you do in a normal functioning facial nerve, this will invite the facial paresis or paralysis. So there are lots of challenges all around the carotid, jugular bulb, dura, all are dehiscent. Entire course of the carotid dehiscent, inner ear destroyed. Was CSF leak earlier which was sealed? I don't know what is the status.
Everyone is, sir, eagerly waiting for the surgery.
Yeah. So in couple of minutes we are starting.
Yes.
The case is ready.
Yes, sir.
क्या है डायग्नोसिस?
फंगल एटियोलॉजी है।
डायबिटिक है क्या?
डायबिटिक में ये हिस्ट्री है, ये कोई डॉक्टर को मंगवा डॉक्टर को कार्तिक करके वहाँ पे उनको रेफर किया। स्वेलिंग है बेसिकली फोरहेड और पेरिऑर्बिटल रीजन में। सुबह सक्सेना सर ने देखा था, हमने तब तक से राज्य सर के पास रेफर कर दिया, हमने कहा उनको दिखा।
First, may require a transposition of the orbit. इसे जरा एंडोस्कोप डाल के दिखाना. क्या कर रहा है? क्या सो गया क्या? आज कर देगा आज. हाँ लगा काट ले. काट ले लगा दे। चौधरी ये कर देगा, आ जाओ। जल्दी 1 नंबर पे जाके 6 पे आ जाओ। बाकी सब निपट गया। फेशियल बचा है, वो जा रहा है टेटोस। 2 फेशियल और भी आने हैं फेशियल। आए क्या और आज? श्योर?
2 आने थे। इसके है ना न्यूरो सर्जन ने जो प्लेट लगाई हुई है टाइटेनियम की स्पेशल की, और एक ईएनटी वाले ने इसकी टेस्ट करी दी है। फ्रंटल में कोई टाइटेनियम की प्लेट लगाई है।
वाई? इसके बाद ढंग से देखूंगा फिर। ढंग से देखूंगा इसका। तो
अजयपाल कुर्सी भी नहीं लगी इसका।
कुर्सी मंगा,
इधर आ जा सर, बुला रहे इधर।
कुर्सी ला। माइक्रोस्कोप
वही है।
हेलो हेलो।
Yes, sir, we are getting your voice.
Yeah. So we are ready for the microscopic picture. I told you the details of this patient, the challenges ahead. So I'll start from the beginning, right from the incision.
Yes, sir.
Knife. Are you getting the microscopic picture?
Yes, sir. Little bit of focus and
Yeah.
fine focus.
हटा यार। Fine.
Yes, sir. I think rotation, yes. Now better, yes.
Focus is good.
Yes, sir.
And see this is the cul-de-sac closure done by the previous surgeon. Now, I am utilizing the same incision, not giving any other one. That was the canal.
Yes.
See this? Hello?
Yes, sir, we can see the first coming out.
Pus and cholesteatoma.
Cholesterol and cholesterol both.
See the cholesteatoma.
Yes, sir.
Lake of cholesteatoma. See this?
Yes, sir.
How useful the MRI is.
Yes, sir. So it's not a granuloma.
Yes.
Right? The person said.
If you bring T1, T2, contrast and diffusion together, most of the diagnosis you can make very correctly.
Yes.
MRI is so versatile. See, when you have such cholesteatoma plastered on the structure all around, this is epithelium.
Yes, sir.
When you think of obliterating, either remove it completely or leave it open to the exterior. See this? This is your dura.
Yes.
See, we sucked out everything. The moment you open the cavity, everything is in front of us. So the cul-de-sac was the culprit for this patient. You know? If the cholesteatoma is exteriorized, it is safe. But
Taking care of regular cleaning.
yes, now we have to develop landmarks. But moment we release, the patient is very safe. Can you see? Bipolar. You do get some time. Now see the most interesting part of the cholesteatoma. See there? Which has gone deep to the carotid artery. Can you see here? See here, the cholesteatoma in the middle.
Yes.
This is all cholesteatoma. Right. Can you see something dangerous? Hello? I told you that the lesion is going deep to the carotid artery. Look at the carotid. Look at the carotid there. Can you see? This is carotid artery. And lesion is deep to it. See this? See the pulsatile carotid. Patla this section. And the lesion is entirely deep to it. Can you see very clear?
Yes, sir.
Dangerous. One can damage the carotid artery. It is so laterally placed. See this?
Yes, it is displaced.
Because of this huge cholesteatoma. Can you see?
Yes, sir.
See this huge cavity deep to the carotid artery. This is petrous carotid hanging in the middle of the cord.
Everything eroded, sir.
Dangerous. The carotid artery overhanging in the middle of the field.
Yes, sir.
Diamond. My goodness, what a amazing situation. Carotid running in the middle of the course. See the pulsations.
Yes, sir. We can see it, sir. Hello, Sandeep, sir.
Yes, please.
Carotid and cholesteatoma there. Can you orient us something about labyrinth?
Labyrinth. I drilled. This is a remnant of the labyrinth here, which I am going to remove now. See, this is the area which is. See, this cholesteatoma is deep to this part of the labyrinth. Remnant. Pardon? See, this is inferior. To orient you, this is inferior, this is superior. This is the vertical petrous carotid coming, turning here as a genu, and then going up anteriorly as a horizontal course. See this?
Okay, last case we have seen the genuine horizontal segment of the carotid.
And see this entire thing you have to exteriorize. Now there is disease deep to this bone. The hidden part of the disease is deep to this bone, which I am drilling off.
Sir, please orient us. जो कि बहुत interesting case है. And if it is a vertical,
See this cholesteatoma. See this cholesteatoma. Yeah, I will orient you. See the cholesteatoma.
extensive disease.
Let me orient you again. See this. Imagine. See this. Yes. This is posteriorly. Here is the sigmoid sinus.
Right.
This is anteriorly where the carotid artery is. This is superiorly where the tegmen is.
Right.
See this? and this is inferiorly.
So
Okay?
you are basically the middle part of carotid is exposed, line exposed, and also
Completely. And the entire disease is going deep to the vestibule and deep to the labyrinth and deep to the carotid artery.
the deep to labyrinth and carotid. Okay.
See this? This is the remnant of the labyrinth. And this is the carotid, and the disease is so far deep.
And the patient is absent. Maybe the surgeon has
All gone. Gone earlier.
all gone. So there are no landmarks.
No landmark for anything.
Grover's case clears me that the disease was lateral to the carotid, and just the disease is medial to the carotid.
Yes.
Probably you are on the stump of patient then.
Yeah. I showed you on the scan the same thing. Remember?
Yes, sir. But when it is open now, it is very difficult.
Nibbler dena.
Yes.
See this all cholesteatoma.
So, sir, what is this in depth?
This is all cholesteatoma lining.
What is cholesteatoma lining? What is that floor?
Flow is dura.
Acha, posterior fossa dura and medial
Yes.
dura.
Yeah, this is posterior fossa dura.
Posterior fossa dura, right. But jugular bulb is covered, I suppose.
See this dura. See the dura underneath.
Yes, yes. So this is criminal to close it.
Yes. और देना वो see this still there is a huge cavity. See this.
How often do you get these type of cases, sir?
Yeah, quite often the same kind of a case, even more extensive than this, I demonstrated in the Mormani source workshop.
Okay.
Almost is a little extensive than this. See the dura. Bluish hue of the dura.
So you will be reconstructing or covering the dura with something?
Still not decided. See, if you are not able to remove the cholesteatoma completely,
You should not cover.
better exteriorize. Here for removal of the cholesteatoma, you have to remove each and every bit of cholesteatoma which is adhered to the carotid artery dura. Then only one can obliterate. See the CSF. Could you see? CSF.
So what is the sequelae of these type of extensive therapy? You have prolapsed dura. What all things can happen nowadays? Like
The-
what do you do?
The most difficult part in this case is a decision to leave it open. That is the most, I would say, this is a difficult decision. And if the final answer is obliteration, but how can you obliterate unless you remove the cholesteatoma 100%?
So this, what type of surgery you do is
Transcochlear. Transcochlear.
transcochlear, mastectomy,
Not mastectomy.
liposuction, or
transcochlear approach to the temporal bone, Peter's bone cholesteatoma.
Postal concourse. Everything is coming perfectly.
Yeah. Already there is a leak. Pardon? Not really. That's the last remnant of the Peter's bone.
Okay. So apparently grade 2D, it's appearing like the segment part. Segment tympani and
Pardon?
sir, we are seeing it as a 2D image. So it is appearing like the segment part. Segment tympani or metadi, something like that.
Tegmen is here. I mean the bone is gone but the area is there.
My it is pulsating, so the brain has already permeated.
Yeah, everywhere is the brain dura exposed.
Okay. Now, okay.
Now if you, there is a fix. If you leave this patient without obliteration with dura exposed all over, there is a chances of future meningitis.
Yes.
Because the cavity is going to get infected with dura exposed can develop meningitis anytime. If you obliterate, the cholesteatoma is there.
There is no way to line it. Have you removed the cholesteatoma deeper to the carotid or you have yet to do that?
Yeah, I am sucking out again and again all the time. We'll show you. Obliterate. Where is this? Bipolar. Dangerous situation.
Very, very scary. Firstly, you have sigmoid sinus protruding there.
Here is the sigmoid sinus. I am not concerned with the sigmoid sinus. I am concerned with the jugular bulb.
Okay. It appears that it is a mobile bone. You'll pick it and it will come out.
Yeah, that's why I am thinning it again and again rather than pulling it off.
Okay. What type of tissue is that?
This is just fibrosis. See the bare bone. This looks like the petrosal sinus. Suggestion दे दो.
So can't you space this?
This is
Like after 6 weeks you again revisit and then.
yeah. According to the Mayosana, this is called the extensive variety, complete variety.
Yes.
Okay, okay, okay. थोड़ा बड़ा देना गोश. So that is the petrosal sinus.
Yes, sir.
और देख. See the site of CSF leak. See the site of CSF leak. Hello.
Yes, sir. Yes, sir.
This is the site. This is the site of CSF.
Yes, sir.
Challenge number one, unless and until you are not 100% sure of complete removal of the cholesteatoma, you can't think of obliterating the cavity.
Yes.
If this cholesteatoma keeps draining outside the ear, which is most of the ear is epithelialized, you know,
Yes, sir. Yes.
and with time it may epithelialize more, a cavity is never bothersome, you know,
Yes.
as far as the danger is concerned. Okay?
Yes, sir. Now this is a quite difficult situation.
Yeah.
Especially when patient underwent already revision surgery several times.
Yes. See all this hidden cholesteatoma.
Yes.
वो देना
But sir, patient did not have any intracranial abscess as such.
yeah.
That's good.
this rent which you are seeing in the dura is probably the same area where the previous leak might have happened.
Yes, sir.
We can easily seal this with a muscle patch. I will show you.
Yes.
See the removal of the cholesteatoma from the surroundings.
Yes, sir.
Give me a gauge piece. Chota. Ball proof there. So this is the limit inferiorly.
Yes, sir. Yes, sir. हाँ डॉक्टर सतीश
Yes.
अभी भी हमारे हॉल में लोग हैं और हम लोग सब लोग कुछ प्रोग्राम कर रहे हैं बिहाइंड द मीन्स एट 5 वी ऑल आर हियर
Crazy.
टेक्स वन तो एक ग्रुप फोटो से हो रहा है जिसमें तुम्हारे पीछे से सर जी की वो आएगी और सारे फैकल्टी वो जो अपने
क्या बात है।
डेलीगेट हैं
Crazy people.
मैनी पीपल ये सब पीछे लग रहा है
See the dura. Cleared of cholesteatoma. Can you see?
यस यस
वो एंगल वाली थी ना गॉश पीस छोटा गॉश आई एम मॉपिंग आउट द डिजीज फ्रॉम एवरीवेयर visibly see all this dura being cleared on this side. बड़ी बॉल प्रोब है क्या? वो लाओ ना, फेस वाली. See the amount of cholesteatoma.
अच्छा उसके डीप जा रहे हैं.
तेज आ. या बड़ी दे. Removing from everywhere, improving exposure slowly. See the sinus bleed stopped. Forceps. Yeah. See, more and more cholesteatoma is coming. See this?
Yes, sir. We are saying
चल गई यार. Yeah.
we write the level
Deep to labyrinth. This is all deep to labyrinth. You cannot use sharp instruments when the walls all around are dehiscent, you know.
They still coming, sir.
Yeah.
So this 140 is a bit different, sir. The curvature and illumination.
This is rhinology.
Nasal, yes, sir.
Mani sir says follow the disease.
And now below you see the jugular bulb. That is the jugular bulb.
Yes, sir. That bluish color structure.
Yeah. We'll show you. ओहो सर्जिकल थोड़ा बड़ा दे. हम्म, That is another. रुक जा. See the part of the jugular bulb.
Yes, sir.
Everything is there in the vicinity. I told you, you cannot. पकड़ना. The jugular bulb is there, carotid artery is there, CSF leak is there.
Dura is exposed, everything is open, sir.
Yes.
सर ये आपके लायक केस है एक्चुअली.
Oh, this is nightmare for anybody.
So notorious.
साफ करना. टेट वर्क बुला. See this jugular bulb and all this venous bleeding is best controlled by.
Surgical and packing, yes.
Yes, yes. Carotid cannot be controlled like this.
Yes, sir.
You can manage the leak, you can manage the jugular, you can manage the petrosal sinus. See
But
this
not the artery.
this side of the cavity I have cleared of cholesteatoma, you know.
Yes, sir.
And this is the ideal case, believe me, for right now, for exteriorization. The reason behind exteriorization is we can monitor.
Yes.
We cannot pack unless you are 100% sure. Because next
Yes.
time this would be 1,000 times difficult.
Yes, sir.
You can see the difficulty of closure now. You can imagine if you reclose it without ensuring 100% removal of the cholesteatoma. Though we have removed, but there is no guarantee about the 100%.
Yes.
You know, थोड़ा muscle patch लेना. See, this is very well exteriorized. The inner
Yes,
part
sir.
also very well exteriorized.
Yes, sir.
आप एंडोस्कोप डाल के एनेटमी बता सकते हैं कि हैव सम स्ट्रेस लेफ्ट.
Yeah, I would, but I cannot leave this jugular bulb like this.
ओके.
I have to hold for a while. See the dural rent?
Yes, sir.
Very obvious.
And the CSF is coming out from there.
Yeah, yeah. I told you there is a history of CSF leak in the past as well.
Yes, sir.
The muscle
So
there.
it may be the same side, sir.
Oi, right. Easy, easy यार मेरा वो जुगलर बल्ब कहाँ है? Okay. Harvesting a little bit piece of muscle. See the cavity till depth is very well exteriorized. Can you see?
Yes, sir.
There is no hidden area.
Yes, sir.
I have drilled this petrous bone extensively. See, earlier was a narrow space between the carotid and now see the entire cavity. See the bone here. See the bone here. Everywhere. अरे यार तेरे को इतना जोर मत लगा यार. बहुत बड़ा दे दिया. एक चौथाई कर. Give me surgical. Still big. बड़ा है.
Sir, with the help of this tissue, are you controlling the jugular bone defect?
No, no, no. CSF leak.
Yes, sir. Okay.
Jugular valve will stop with the surgical only. See? Both the things in place.
Yes, sir.
The muscle was patched to control the leak, and this is to control the jugular bulb. See this lateral epithelium I don't want to disturb. In the medial part which I want to exteriorize. Can you see?
Yes, sir.
So, was inserted into the rib there in the dura,
Yeah, the half in, half out.
compulsory.
Yeah. This is exteriorized.
Still coming, sir, from that depth.
Yeah.
Maybe the last part, sir.
No, see, cholecystoma cannot be removed like this. You have to be 110% sure. And in such areas where a lot of hidden areas, you cannot be that sure.
Yes, sir.
That's why I am forced to leave it open.
That will be a better option, sir.
Once cavity is reepithelialized, it can drain outside. That is acceptable.
Can copious irrigation can help to remove this cholecystoma?
Not really.
Sir, is there any role of using linear lactate for irrigation in such cases, sir?
Not really. What best is to leave a good exteriorized cavity.
Still something is seen, sir.
सर इसका फॉलो अप आइसोकॉन में जरूर बताइएगा सर.
जरूर जरूर मैडम.
We have enjoyed today thoroughly. Obiomas was wonderful. Cases was perfectionist job. And osteomyelitis we have all learned a lot.
Forceps there. क्या हटा यार forceps there. Thank you your valuable time, madam. That was wonderful to interact with you.
सीखते रहेंगे सर, आप सिखाते रहिए. We all are following you. Thank you.
ये क्या आ रहा है ऊपर से देखना. क्या? Yes. So now we have a exteriorized cavity. क्या रहा बाहर लेटरली कहाँ से ब्लड आ रहा है देख लेना यार. देख ना उसको उठा के. Yes.
Thanks a lot, sir, for wonderful demonstration, sir.
अरे थैंक यू.
एकदम फुल बैठे हुए हैं, सर. Interview देख रहे हैं, sir.
थैंक यू सो मच फॉर योर अटेंशन.
लोगों का सम्मान कर रहे हैं, सर.
अरे क्या बात है. यू डिजर्व.
Okay, sir. कोई फोटो खींचो भाई.
थैंक यू ऑल.
अभी सर भोपाल आए, सर, फिर जरूर मिलेंगे, सर.
इसको रोकना चटवा यहाँ.
From भोपाल है, सर, चिराग मेडिकल कॉलेज.
तो रोकना क्या है.
सर, डॉक्टर प्लीज.
यस सर.
सर स्टार्टिंग से सुबह से बैठे हुए हैं.
क्या बात है.
इस बार उनको बुके देते हैं. दोबारा किसी और
Hello, sir. Please, sir.
यस सर.
I am Dr. Gorakhnath from Ayodhya, nearby Lucknow. Sir, I request you to keep posting your surgical video on YouTube so that we can learn there also. I have learned many surgery from your YouTube video after repeated watching the YouTube video.
श्योर सर श्योर.
Yeah.
आप यहाँ पे गाड़ी से क्या काम? गाड़ी से
इसलिए तो नहीं जाने.
नहीं.
कॉटन बोल देना. वो गॉज भी देना.
वो दिया है. Thank you very much, Satish Bhai.
थैंक यू बॉस.
Ultimate.
Okay, you can disconnect. My case will continue for another at least 1 to 1.5 hours. I have to remove. I have packed inside now. Remove the lateral cholesteatoma. Remove. I may have to transpose this carotid artery. Or remove the cholesteatoma from underneath. So I have a lot of job to do.
Because we have to check out from the
Yeah. I know.
So thank you very much. And
Are
all
big,
the delegates,
big thanks to Pachori boss, one and only one.
absolutely.
You have made this ISOCON memorable with a new benchmark. I think Meghnad will have a tough time next year to beat this.